Namaste, my dear brothers and sisters. The love and blessings of the Mother and Sri Aurobindo to all of you from Sri Aurobindo Ashram, Delhi branch. I have with me here today Professor Vivek Jangira, uh, an orthopedic surgeon who is the professor of orthopedics at the Lady Hardinge Medical College in New Delhi. Uh, Apart from the position that he holds, I've had the privilege of knowing him for the last several years. And what I've seen is that he's one of those unusual doctors practicing modern scientific medicine who try to prescribe as little of investigation and treatment as possible and try to empower the patient to work on himself or herself to get better, make the best use of the healing powers, the healing capacity of the body itself. For example, recently I had pain in a joint and I thought I had osteoarthritis. And that is what we are going to talk about. We are going to talk about osteoarthritis today. Uh, so I thought I had osteoarthritis and he just examined me and said, no, this doesn't look like osteoarthritis. And then he moved my joints, both sides. And then he said, your joints don't feel like the joints which have osteoarthritis. He said, your movement feels the way the movement of an average 40, 45-year-old would feel. I'm 75. So what is the conclusion? The conclusion is I suffer from delayed development. What most people achieve at 40, I have achieved only at 75. Okay. So he didn't depend upon an X-ray to see how much changes have taken place inside the joint, and therefore what age uh, would give that type of an appearance in the X-ray. Nothing, just a little feel of how the joint felt when he moved my legs, and he said, "This is the type of joints you have." So now you can understand what type of a doctor we have here with us today. So welcome, Dr. Jangira.
Namaskar, sir.
So. Uh, Osteoarthritis is, of course, one of the commonest diseases that you would be seeing. What are the usual symptoms, the presenting symptoms with which the patient comes to you?
The most common presenting symptoms is always the pain, and few of them they report early with some clicking or some sounds. The pain in the primary disease may be while only doing some activities like climbing stairs or after prolonged sitting in squatted position. They may have some pain for some time. Gradually on walking that disappears. So usually in our country, most common presenting symptom is pain while climbing stairs is the most common symptoms. And then in advanced disease, you can have all the symptoms like pain, deformity, limitation of range of motion, all these presentations we get.
And that's a good point you brought out. Some people go to the extent of changing the house. If they're living on the say, second floor, they try to shift to the ground floor because of this difficulty of climbing the stairs. What would your advice be to such patients?
I would like to give you one simple example. When we wash our clothes, we dry it on a string. If suppose that string has a capacity to hold 10 clothes at a time, then the string will not break unless you cross on the 11th cloth. If you keep on hanging 9, 10 clothes over it, it will maintain its um, uh, structural integrity. So same happens in your osteoarthritis. In early part of the disease, your joint has much capacity to reverse the damages which is already there. And body has got wonderful capacity to even go back 10 years as far as recovery from the damaged condition is there. So we assess and we calculate how much load can be given on these knees without further damaging it. In the example I have shared, 10 clothes can be hanged on that string. Similarly, when your knee is on very early stage of osteoarthritis, no activity is restricted. Instead, those activities which are helpful in regeneration of the knee, they are advised to go more, and no activity is restricted. While in an advanced case, where the knee is totally damaged, then we advise them not to sit on floor like squatting or sitting crossed legged, and avoid further climbing of stairs and all that. So that only happens in advanced disease, not in early part of the disease. Early part of the disease, we gradually increase their activity. So weight loss plus activities, this repairs all the damages. While in advanced disease, this becomes difficult. So we advise them to do only that much is possible.
So it depends primarily on the degree of damage that the knee has. Now, going back to that analogy of the 10 clothes being put on the same line while drying up, and the 11th one actually breaking the string, uh, would it also mean that if the damage is such that the person can easily climb one floor but not two, then he can climb slowly one floor, take a little rest, and then climb the second one?
Exactly, sir. What happens is when you want to increase your capacities, then this is the best policy. Whenever you get tired or your limitation reaches, you take some rest, then again do that much. So gradually, after 1 or 2 months, you will suddenly realize that now I can climb two floors at a time. So that is a very good policy, and I employ it in my activities. I advise my patients to increase their activity if they want to 10% per week. So some young enthusiastic, they may ask, "Ki I should be doing very much high activity." No, any physical activity should be gradually build it up. Otherwise, if you overdo in one sitting, then it is going to harm or damage in one or the other way. While our body is a live structure, it adapts. So, increasing your exercise capacity, other things, 10% every week will actually build it up. And if you overdo, then you may have some damages also. So, gradually you build it up. It can be built very well in due course of time. One should not be in hurry.
Thank you. Uh, Now, what are the type of manifestations which are most disabling for the patients?
Uh, uh, Usually, two things they complain the most. Apart from their activities, apart from their in their professions. One is climbing stairs. The other one is while doing something, sitting on floor like squatting or crossed-legged sitting. So these two are the major disability components to start with initially. The third one is they cannot walk for long. They start feeling pain in the knees and they need to rest. So these are the three disabling factors which trouble them the most.
So the patient really has to be encouraged to keep up the physical activity because otherwise the person may have the tendency to go on limiting physical activity more and more to avoid pain.
Yes, and that will be more damaging than doing any good. So gradually, we encourage them to do those exercises which help in regeneration of the knee. That is one simple exercise is static quadriceps exercise. That is excellent exercise which can be done in any amount of knee damage and which can be done by anybody at any place. Such a beautiful exercise. It's like eating when you eat. Suppose we eat 3 times in a day. If I ask you not to eat or to eat 3 times in a week, then it becomes difficult for you. It is so easy to understand. How can one survive while eating 3 times in a week? So similarly, the knee needs some food. Our cartilage doesn't have direct blood supply. So the nutrition comes from that squeeze which the knee gets. Like in sponge, when you squeeze, the fluid gets out. So all toxic material in the cartilage that gets out while you put load on your knee. When you relax, then again they swell up with fresh amount of healing fluids. So that static quadriceps does that healing to the knee. So static quadriceps exercise is one thing which should be encouraged, and it should be done multiple times in a day. It will not be that effective when you do it once or twice. Say do it 100 times or 200 times in a day. That can be done standing, lying down, or sitting.
sort of to circulate the synovial fluid and to increase the production.
Yes, as well
And
as to reintegrate your neuromuscular thing also. The muscles, because of that pain and inactivity, your muscles also get deconditioned. With these exercises, your knee realigns the alignment, mechanical axis that gets corrected when you exercise with this. Your muscles, they get back, the pain decreases. So it helps in many ways.
I mean, since you can help the patient a lot, especially if the patient is willing to help himself or herself. Uh, but by and large, the pain may not go away completely. And so you very often you tell the patient to learn to live with pain. But not enough is always told about how to live with pain. So would you like to elaborate a bit on that?
Yeah, see, now I am into orthopedics since last 25 years.
Mhm.
So this confidence, what I am talking now, is you can say last 5, 6 years. So there were many unsolved questions in my mind regarding osteoarthritis, exercises, their outcome. So once I have seen those patients over the years, followed them up, then this confidence is there. It is written in the books. There are many other things that is written in the books, but basic my confidence after reading those books and seeing my patients follow up, I am to this conclusion. One is osteoarthritis is a disease which have remissions and exacerbations. So in a year, 2, 3 months you may be troubled, but rest of the 10, 12 months you may not have anything as an analgesic that is required. So, when once you should not lose hope that now my knees are gone and they will not reverse. So, with 2, 3 months of exercises, they again come back and no pain. And that lasts for many months or maybe years. I've seen many patients for last 10, 12 years. With these exercises, they get rehabilitated very well. So, one is this exercise. Uh, I can say that the painkillers or analgesics in my practice, they are only to help you exercise, not to modify the disease, not to change the your cartilage and uh, for your long term relief of pain. It is only so that you can exercise as soon as possible, and with exercises the pain goes rapidly. Without exercise the pain may last long. So, and as soon as you start taking your medications, depending on your stage of the disease, you may get relief. So, analgesic only while you are not able to exercise. And there are pain is always subjective. It depends not only on the disease, on the personality, on the circumstances, even on the same person, different time, different emotions, the pain reflection, perception, it changes. So pain can be modified at multiple levels. Even your emotional or thought process, it has lot to do as far as pain management is concerned. So yes, we need to work in our thought process to control the pain also.
This is a very important point you made that how much disability it causes depends not only on the pain but also on the person who has the pain, his personality. Uh, these truths never really change. These are things doctors have known for a very long time. In modern medicine, if I'm correct, I think it was William Osler who said, pointed out that as important as the disease is the person who has the disease. Perhaps the latter is more important. And we'll come to painkillers in a moment, which you talked about. But before that, you talked about the remissions and exacerbations in the disease. In Ayurveda, according to Ayurvedic wisdom, uh, osteoarthritis is a Vata disease. That's because of excess of Vata. Now, there's a seasonal variation in the dominance of Vata in the atmosphere. And they say that it is most vitiated in the rainy season. Does your experience confirm that the symptoms actually go up during the rainy season?
Yes, during certain times, these disorders, I see multiple patients complaining that they have exacerbated pains um, and their activity limitation also. So in our allopathic medicine also, psychiatry, the moon cycle has direct impact on our emotional status. So similarly, these things they are there. Even when some orthopedic implant is inside the body, so these environmental changes they do bring in pain in that particular patients during that time only, not otherwise. So yes, everything is related.
Another popular feeling is that, especially in the rainy season when there's a tendency for the disease to exacerbate, uh, sleeping in an air conditioned room or with the fan on at a high speed, not enough clothing or something while in bed, when all these things can also exacerbate, particularly in winters if and the room is very cold. Now, do these things really have much effect? And
Yes, the effect of cold on tissues is very well explained. There is no doubt about it. Uh, uh, as with the other things, with cold, the tissues they become little stiff. With some exercises, with some warmth, the stiffness decreases. So that is 100% related. The stiffness is directly related to the amount of uh, your activity and the coldness.
that reminds me of another thing, a question that I can ask. Uh, in physiotherapy, very often for pain, they recommend either cold or heat or a combination of both, alternating cold and heat. So, uh, what is the logic behind this, and what type of advice would you give to patients who have pain due to osteoarthritis?
There are other kinds of arthritis also, other than osteoarthritis. Osteoarthritis is, we consider it as a degenerative process, but somewhere some inflammation is there in that also. Other arthritis, they are basically because of inflammatory process. So we need to distinguish between these two while applying the principle of heat and cold therapy in them. So in osteoarthritis, this heat modalities they do help. In inflammatory, we try not to give heat modalities. And as we have discussed, this pain modulation, we have a gate cycle also where some skin irritants they decrease your sensation of pain in the knee. You apply some emollients, some counter irritants on your skin around knee joint, and that decreases your pain perception also. So whenever there is any inflammatory or these, even cold as cold sensation also acts to relieve that pain.
Now, let's turn to painkillers. Uh, you can say whatever you think would be helpful to the patient, like say, which are the painkillers which are relatively safe, how long can one go on taking them regularly, and how one can overcome dependence on painkillers and things like that. Whatever you think is relevant.
For layman, I can describe the painkillers depending upon how it acts. One is peripheral where pain stimulation is blocked by COX-2 inhibitors, and the other one is in spine where you have that opioid-based analgesics like Ultracet, other painkillers, pregabalin, Ultracet, Fortwin, Finargan. These are opioid-based analgesics. They primarily act on your spine and brain. They block the transmission of pain. The other painkillers we described in inflammatory to reduce the inflammation also. like endomethacin, diclofenac. These are strong anti-inflammatory drugs. So these drugs, they have side effects. What is side effect? Basically, these are the effects only which we don't require. So we call them side effects. I don't want sedative effect of Ultraset. So that is side effect for me. Otherwise, that is the effect of Ultraset in our body. So different drugs, they have different mode of actions and they have different side effects. So to start with, paracetamol. Paracetamol in whatever dose controls your pain is the best and safest analgesic you can have. Rest, others, they gradually increase their side effects, like these non-steroidal anti-inflammatory drugs. They have damaging effect on your GI system, where you can have ulcers, acidity, in your kidney, where you can have some renal damage on prolonged take of these non-steroidal anti-inflammatory. Then there are steroidal or opioid-based analgesics, which have some side effect as sedation, reeling of head. So those who are in working on machineries or those who drive regularly on road, they should avoid these sedative analgesics. And those who are already having liver disease, then also paracetamol may not be a very good substitute. We look for other diseases. Some may have renal diseases, so we may have to go for Ultraset or paracetamol because that is least damaging to the kidney. So depending on the patient's O, we decide on analgesic. But otherwise, if someone is normally O, then paracetamol in lowest possible dose. Now we have delivery techniques, nanotechnology. So this paracetamol pain relief, crocin pain relief, that utilizes two, three different technologies, and 650 milligram paracetamol is good enough for pain relief. Otherwise, you can take one normal adult male can take 1,000 milligram of paracetamol, and this paracetamol acts almost 6 to 8 hours. Can be repeated in 4 times in a day. So that is considered more safe than any other analgesic like Voveran. Ultraset is habit forming. All opioid things, they are habit forming.
Uh, but on the whole, I mean, how would you uh, advise the patient to limit the use of analgesics in general?
I counsel my patient very well. See, I am prescribing you analgesic on your demand only, and from my side, only the maximum indication for you for analgesia is only 5 days or 5 to 8 days. After that, you should be free from any analgesics. So this is how I advise my patients. In these mean times, if they pick up on the exercises which I advise, then they themselves can limit the use of analgesic.
So sort of tide over the acute phase or the phase of severe symptoms,
Yes.
and also to perhaps break the uh, pain spasm uh, cycle.
Yes, sir.
Pain leads to spasm, spasm leads to pain. So if you relieve the pain, the spasm goes, and the pain due to the spasm automatically then goes.
Yes, sir.
So to break that cycle.
Yes, sir.
So that much
Yes, sir.
is necessary. Uh, Other modalities of treatment are also used, like intra-articular injections. Would you like to say something on that?
Yes. Basically, now we have two, three types of intra-articular injections. One is steroid injections. So local intra-articular steroids, if you are not diabetic or suffering from any infections, then intra-articular steroids, they do reduce inflammation and pain uh, in the knee joint. That is mixed with some local anesthetic agent like bupivacaine and injected into the knee. That gives excellent analgesia and pain relief for a few weeks to months. The other newer modality injections, they are viscous injections. They say that high molecular weight, proteinous substance that is viscous in nature, claiming to replace the original joint fluid. That can only be given in very early stage of osteoarthritis. We hardly get. I am in a government setup. Most of my patients, they are poor patients. We hardly get those patients who are early into disease. Otherwise, also in early part of the disease, the exercises does wonder. The normal production of your joint fluid and everything can be restored in early part of the disease. So nowadays, in my practice, I don't go for these viscous agents that are costly, some 12,000 to 20,000 injections per knee. But I don't feel the need for these injections in my practice.
And how about the option of surgery? When is it indicated? Particularly, total knee replacement, total hip replacement. That sounds very fascinating. That you just have a new knee or a new hip.
Yes. See, there are two sides of the story. One is indication from the surgeon. The second one is leverage to the patient to get the knee operated for total joint replacement. Uh, from surgical point of view, if I see some very deformed knee with limited range of motion, the complete range of motion is not there in the knee joint, then I can suggest them if that total knee replacement will be better for you. Otherwise, the best indication for total knee replacement or under knee replacement is your limitations of activities of daily living. Patient can themselves decide whether to go for this surgery or not. Simple decision making criteria are: if you are not able to manage your day to day living, your profession without taking analgesics, then it is better to get your knee replaced than to take analgesics for long duration of time.
So the main thing is the functionality, if how far the person is able to perform the usual functions which are necessary in
Yes,
everyday life. Uh, so if that is becoming difficult, then knee replacement
with few days
or
of
hip replacement.
analgesic exercises, if you can improve upon and you are able to carry on with your activities of daily living, then joint replacement is not advised. If that is limiting your activities, like daily activities, climbing stairs, or you are not able to move within your house, and you have to take analgesics. You are taking analgesics 2 times, 3 times in a day for last 1.5 to 2 months, and you are not getting rid of these analgesics, then yes, one should go for joint replacement.
And he said that age also has something to do with it. You do not do this knee replacement or hip replacement in a very young person because this new joint may not last very long. And therefore, the person may then require a repeat surgery.
Very, very true, sir. Usually, these joints they have life of some 15 to 30 years. Newer implants they claim some higher bow, but after 15 years, the components, uh, these knee joint replacement components, they get deranged. That plastic gets weaned off. So that requires again a surgery. And the second surgery, the success rate of second surgery is not good. Uh, with aging of the patients, the comorbid conditions they are high. The risk, the surgical risks, they are also increased. So we recommend it should be done in later years so that the second replacement may not be required.
Of course, I mean, coronary artery disease and osteoarthritis is a little different type of diseases. One is due to blockage of arteries, the other is due to degeneration of cartilage. But in coronary artery disease, it is sort of quite well known that the person may have recurrence even after bypass surgery, but the recurrence can be delayed or prevented altogether if the person follows up the surgery with lifestyle modification. To what extent would lifestyle modification help a person with osteoarthritis uh, in avoiding or delaying repeat surgery after replacement of the joint?
Once the joints or knee joint is replaced, to increase its life, the most important thing is not to gain weight.
Mm.
Weight should not be, otherwise wear and tear will become high. Your muscles may not support. Your muscles, they should be conditioned so that no abnormal forces they are acting on your knee joint. Very heavy activities, they need to be now avoided. Suppose a person want to be a marathon runner after knee joint replacement, then it is going to wear and tear very early. So we need to restrict ourselves so that we can maintain our muscles and uh, body in a proper healthy way, not too less, not too more.
So, somewhat similar principle applies here also, which means if the person maintains or reduces, if necessary, the body weight uh, after surgery, then that would be helpful. So, just having new arteries, fresh arteries from the bypass, or having a new joint should not lead to a smug satisfaction that now I have got a new set of organs and therefore I need not worry.
Yes, sir.
Lifestyle modification would be still helpful.
Yes, sir. Definitely, sir. One of the contraindications for these joint replacement surgery is overweight.
Mm.
We don't recommend knee joint replacement surgeries in overweight individuals. They wear and tear very early. The results are little unpredictable. Even otherwise, in an osteoarthritic man, if someone loses weight, say even a 65 or 70 kg female, if she loses 5 kg of weight, then there are 50% chances of improvement in symptoms. So weight loss is very important.
So, Dr. Saab, any other general advice that you would like to give to those who have osteoarthritis?
Yes, first and foremost, you should always try exercises. 3 to 6 months at least. Don't give up just 15, 20 days or 1.5 months of exercises. It takes some time to get relief from this osteoarthritis. And I am following my patients, those who are without surgery for last 10 to 15 years, who were advised otherwise to go for total joint replacement. So yes, these exercises, lifestyle modifications, weight loss, they do wonders. So one should resort to these things.
Any other afterthoughts that you have?
We have almost covered uh,
All
everything.
important ground we have covered.
Uh,
Huh?
the one thing we always I can carry on in this talk is um, there are two sets of patients: those who go for joint replacement. After joint replacement, there are happy patients and there are unhappy patients. Some say, yes, I am very happy, I am very satisfied. The other one says, no, somehow, somewhere I have some pain. My feeling, my knee doesn't give me a good feel. I have the limp still with me. So, if we can know pre-hand before surgery that this patient is going to be in the basket of unhappy
Mm.
ones, so that should be avoided. How this can be avoided? See, what happens is in total knee joint replacement, the proprioception, in most of the cases, there are some ligament sparing surgery also, but most of the time, that proprioception is not as good as which was with the original knee.
Mm.
So, intelligent patients and those who can detect minor changes in their bodies, they miss something. So, they become unhappy patients. So if you are able to manage your life, you are just going for these surgeries for to start jogging again, or you want um, with very mild pain or very mild disease, you want to be pain free with just one shot of surgery, then you would definitely be coming into basket of unhappy patients. So always try all exercises, weight reduction, lifestyle modifications, and then if it is not there, the relief is not there, you are still going for analgesics, then these knee replacement or hip replacement, they are 100% successful surgeries in those patients. So one should go for it.
So one should look at the positive part of it, that yes, after surgery, I'm much better than I was before. One
Yes.
should not expect perfection,
Yes.
perfection of the type that once had as a young person.
Pain is
Mm.
almost gone, but other things they remains. Like you cannot sit in a squatting position. You cannot sit cross-legged position because knee range of motion is 0 to somewhere between 110 degrees.
Mhm.
So squatting becomes difficult after that, and it is not advisable also with newer implants also.
And a little inconvenience, as you said, because of the loss of proprioception.
Yes.
And for those, I mean, who may not have understood what proprioception is, it is the sense of position, the sense of, uh, where the joint is now. Because, as we walk, we have an intention to perform, say, this much movement. Then there's a moment to moment feedback. Now this much is over, and the now this much remains. Now this much is over, this much remains. And that helps us a lot in having a smooth, well coordinated movement. Now, because the nerves have been damaged or gone during the surgery, and the new joint has been not been innervated, has doesn't have the same set of nerves as the original had, this sense may be not there or will not be perfect. So the person has to be prepared for it. And if the person is prepared and willing to accept that, well, the new artificial joint cannot be what the original natural one was. After all, we can't mimic nature perfectly. So if he's satisfied with that and is willing for a little compromise, he has that sort of personality, he probably will be able to adjust even to this loss of sensation, because the body has a remarkable capacity for resilience. And if the mind is positive, the person can adjust to a lot of limitations and this type of defects. And the body probably would also have some sort of compensatory mechanisms which will come into play over the next few months or years, which will compensate for this loss of proprioception. So the person will not feel as unbalanced or feel the movements as discoordinated as immediately after surgery. Isn't it, Doctor?
Yes, sir. Yeah, sometimes it takes 2 years
Mhm.
to develop all these extra.
Mhm. So thank you, Professor Vivek Jangira.
Thank you, sir.
Thank
Thank
you
you
for
very much.
sparing your precious time and sharing all these useful and valuable details at
Yes.
such length with all of us.
One
Sure.
I want to share one thing. There are few things which you can say I have learned in my practice by chance or by God's grace, whatever you may say. Uh, Suppose if there is a patient which I am not able to understand, what are his presentations, from where it is coming. I examined him completely. I went back in the evening. I opened up my books. I opened all references. Still, I am nowhere, and I could not find. Then again in the next OPD, the same presentation with other patient that comes, and that perplexed me again. So I tried it twice, thrice to look into literature or my background. Sometimes it becomes very difficult to get an answer. But by God's grace, what happens is immediately after that patient, the next patient comes with an answer to all my questions. So this is how I have learned few things, and that really reinforces my thought process, my belief in natural body healing capacities, principles of Ayurveda. So one simple things which I have learned from Sir, and I admire him, in my life is his book on nutrition. I always thought that it to be the right way, but after reading the book, that reinforced my thoughts like anything else. So these things they do happen, and I thank you very much for that.
Well, I mean, uh, what we do not get from books, we can learn from patients, or you can say that through experience. But then it's the patients who give the doctors their experience.
Yes.
So that way, all good doctors are grateful to the patients for
Yes.
giving that experience which books were unable to give. Thank you.
Thank you.